Greetings, everyone, once again. Welcome to the 188th session of the Online Optom Learning Series, or OLS. And today's session is a bit special. Apart from the usual support we get from the education supporters, we have Avellino Group who is supporting this session and bringing the latest technology to you, which we are going to hear from two esteemed speakers who have joined us all the way from Korea. So today we have with us Prof. Kim and Dr. Ryu. So just introducing Prof. Kim is a professor of ophthalmology emeritus at the Yonsei University in Korea. He is well known for his work in corneal dystrophy. He is a part of the Corneal Dystrophy Research Institute at the university. He is an expert in the basic and clinical research about TGFBI-related corneal dystrophy, and also an expert and works very hard in the diagnosis and treatment of several TGFBI-related corneal dystrophies. He is a recognized global leader for his expertise in granular corneal dystrophies and has over 140 authored peer-reviewed manuscripts and publication to his credit. He is also a medical advisor on the board of the Avellino Lab, USA. Welcome, Prof. Kim. Thank you so much, for spending today's evening with us today.
Well, thank you. Thank you for your very nice presentation and introduction. And I personally thank you to company Avellino, which has invited me to say these kind of things in front of you. And it's my honor to introduce the genetic test on TGFBI mutations to you this evening. Well, I'm Eung Kweon Kim, and then I had been a professor of ophthalmology in Yonsei University. And then because of the age limit in Korea, I had retired and now remained as an emeritus professor. And then I had been in this kind of research for about 20 years or something. Then I wrote about 30 to between 30 to 40 SCI indexed articles in the international journal. And I have left the Yonsei University because of my age limit, and now I'm working in Sabit Eye Hospital, but still many of the Korean doctors are sending their patients to me, so I'm still somewhat active in the treatment of this TGFBI mutated corneal dystrophy patients. And as I was introduced, I'm a medical advisory board member of Avellino Lab USA. And if you look at the cornea, well, this is about corneal epithelium in human, about 3 to 5 layers, and then here's a stroma, and then this is the Bowman's layer, and this is the stroma where the keratocyte lives, and this is the descemet membrane, and this is one-layered corneal endothelium. And then, what is corneal dystrophy? Well, that's a group of hereditary disease in which abnormal protein accumulates in the cornea due to a gene mutation. So because of the gene mutation, it is usually bilateral. And then many genes are found. And then if we just show you the case of the homozygote of the TGFBI, that's a Avellino corneal dystrophy. This is the normal cornea, and this is the mutated one. So it's very prominent in the shape through the slit lamp, basically. And then among them, there are so many corneal dystrophies, and among them, there are some group called TGFBI induced gene corneal dystrophies. That's TGFBI gene is a gene located in the number 5 chromosome, and then it's about 683 amino acid. And then, so this is TGFBI is the transforming growth factor beta induced gene. So as you know, there are the gene so-called transforming growth factor beta, which is related with wound healing. And then when that gene is activated because of the wound, then this TGFBI gene is also activated, and this TGFBI gene makes TGFBI protein. So this is the case exacerbated after Avellino corneal exacerbated after LASIK, and this patient has the disease of Avellino corneal dystrophy. So there were some small spots here and there, but after LASIK, the LASIK means we are introducing the wound to the cornea, and then when the TGF-beta is activated, then TGFBI gene is activated, and because of the mutation, then mutated TGFBI protein is made, and it deposits along the interface made by the LASIK. So I began to do the research when I see this kind of patient first in the world. So it was the beginning of my research. And now, among that 683 amino acid, there are so many variations. So granular corneal dystrophy type 1, so-called GCD1, it has R555W mutation. Granular corneal dystrophy type 2, R124H. It had been called as Avellino corneal dystrophy before, not anymore, but that Avellino lab made its name after this Avellino. And the reason it is Avellino is that the patients, long time ago, we did not make the difference what is GCD1 and what is GCD2. We just called that everything granular corneal dystrophy. But in 1988, somebody found this kind of different one, and the family came from the Avellino district, Italy, and so the founder thought as if this is a very new one, and so he named the dystrophy as Avellino corneal dystrophy. But now, because of the gene inspection, we know that it is very common in the world. But so we made a difference saying that GCD1 has R55W and GCD2 R124H mutation. So let's make it easy by calling Avellino or GCD2. And then lattice corneal dystrophy type 1, that is R124C mutation. Raspular corneal dystrophy, that's R124L mutation. And Thiel-Bonke corneal dystrophy, that's R555W mutation. So there are very famous 5 mutations are in TGFBI mutated corneal dystrophy. And I want to just say that Avellino Labs universal test covers all of these 5. And if we just see that the phenomenon or phenotype of GCD1, it is just, it looks like this when the patient gets old, or it can show like this. So it is basically granular. We call these things granular shape. So GCD1 shows just granular finding only. And GCD2 or Avellino corneal dystrophy, it shows first when the patient is very young, then it shows just some granular things. And with age, it shows this kind of some linear lesion, or sometimes it is called lattice lesion. And then when the patient gets old, this kind of diffuse haze comes out. So Avellino corneal dystrophy shows granular, lattice, and diffuse haziness. But it can be a little different from patient to patient. And then this lattice corneal dystrophy type 1, well, there are some kind of lattice lines here and there. So these lattice lines are composed of amyloid. And then ricebular corneal dystrophy, it's in the Bowman's layer, like this. And then very similar one, this one also in Bowman's layer, it is called Thiel-Bonnke corneal dystrophy. So this is the TGFBI related corneal dystrophy. And then this is a homozygote of Avellino corneal dystrophy. It is like this. And if we just ablate the cornea with excimer laser, so-called phototherapy, we just call that PTK, phototherapeutic keratectomy, then it becomes clear because it is a little anterior portion. It is located somewhat anterior. And when you ablate that, it is just clear. But 3 months later, it recurs like this. And 3 years later, it recurs like this a lot. And so if we focus on the GCD2 or Avellino, then as I've told you, that's R124H mutation. And in South Korea, it's very common. So heterozygote is very common. And so, as I've told you, it starts with granular and lattice deposit comes out and diffuse stromal haze comes out later. And it makes the vision to be decreased. If we look at that Avellino in a lifetime, then about 12 years old, there are some granular deposit only, and 14 years old, there are some granular deposit, and 25 years old, look at this one, there are some granular deposit only. So 7 or 8 visible white dots. And in some different patients, just 3 or 4 dots in 28 years old, and this is 48 years old, and this is 74 years old. It's okay. And so until now, just ophthalmologist just told to the optometrist just explained to the patient that, well, this is a genetic disease. We cannot do anything. That kind of things was a traditional explanation method to the patient. But in Korea, there had been a storm of LASIK before. And so when we don't know well about this one, some ophthalmologists did a LASIK on this side with the hope that they can remove this kind of deposit and they can fix up the myopia. And then this patient came to me for the first time in the world. At the first time, I did not know what it is. But this is 7 years old. this is LASIK, not LASIK. And so I had to do some research because every ophthalmologist in Korea just sent their patient to me because I had been a chair of the Korean Society of Cataract and Refractive Surgery. Then let me just say you one thing, that when there is some mutation in one chromosome only, we call this one heterozygote. And in both chromosome, we call this one homozygote. And then the prevalence rate in South Korea is about the heterozygote, 1 out of 870. I published that in this ophthalmic epidemiology, with a proof how we made that kind of calculation. And so this kind of TGFBI gene is very, very widespread in the world. So I believe when the South Asians, look at the slit lamp for a long time, I think you can find some of them because it could be found everywhere. So this is a 25-year-old female, and then this is and that surgeon did one eye LASIK only. So virgin cornea without treatment, it's like this. But the other one, where the LASIK has done, it's like this. And the patient could not see well. And then this is just a virgin cornea without treatment. But if we look at through this area, then you can see this white dot is located in the deep portion, while these two is located in a somewhat superficial. Okay, so this white one or lattice one is located in deep, while this granular one is located somewhat superficial. And when you do the LASIK, then this kind of white deposit is along the interface between the flap and the posterior remaining stroma. So in the case, I published that I just remove the flap, I amputate the flap away and do some PTK on this kind of posterior remaining stroma, just mimicking that kind of photorefractive keratectomy. And then when this interface is very deep, then sometimes I had to the corneal transplantation, deep lamellar keratoplasty. And then this virgin cornea, this lattice line is located very deep. In the case, we can do deep lamellar keratoplasty or penetrating keratoplasty. Still, I prefer deep lamellar keratoplasty because the endothelium in this series is normal. Anyway, this is 2 years after LASIK. So, and even with the SMILE procedure, just one-eyed SMILE here, and then we can find out this kind of white dot recurring at the interface. So, refractive surgery touching the cornea is contraindicated. So we need prevention. And variable of phenotype of granular corneal dystrophy type 2 among Korean 20s, I mean, with an age of 20s. This age is where, who are in the age of 20s are very active and receiving the LASIK or LASIK. So does absolutely clear cornea with GCD2 exist? And do we need genetic test? This is a question. Just let me show you that this is the homozygote. Just one is heterozygote. And this one R24H mutation here, and another one, for example, arginine 257 proline here. We call this one compound heterozygote transform. Okay. Then now you can see, oh, this is a homozygote. It's very easy. Then you can see these kind of things if you just look at, if you are with a slit lamp for a long time, so 28-year-old, and visual acuity is very good because the light gets in there. And then this is compound heterozygote, so R124H mutation and the opposite allele H174D mutation. So it's very rare, but if you can have that kind of system in your country, that next generation sequencing, in which is covered by the Avellino, this is the name of the test provided by the Avellino lab, then you can find this one easily. And then, does clear cornea with GCD exist? Well, at first time, I had thought as if I could find out every GCD2 patient with a slit lamp, because I think I was so experienced. And still, the ophthalmologist in Korea who had passed the fellowship with me, well, they think they can find out easily with a slit lamp because they did not see this kind of cases. And so now I show you the very interesting cases to you. This patient, 26-year-old female, just visited us with 2 previous GCD2 positive test results in her hands. Well, I went to receive the LASIK, and then the doctor said, that doctor who did this kind of things routinely told me that you cannot be a candidate for LASIK. And she visited another clinic, and then the patient got the same result. In Korea, we have a lot of cases exacerbated after LASIK or LASIK. And so many clinics do this kind of GCD2 gene test routinely. So this patient was checked, and then she came to me, and I need your confirmation. So I looked at her, I searched her cornea, knowing this kind of result already, and could not find anything, even with this kind of retro illumination. So I just repeated the PCR test with a buccal swab and blood. She came to me 3 weeks later, and at that time, the result also positive also. So now I've got 3 positive results, and I had to find out something. So I searched for her eye for 20 minutes, and then found out this kind of very small dot. Can you find it with your slit lamp? Well, as far as my eyes, I could not find out her dot when she came to me with two previous test results. And then this is the other cases that this is from local clinic where the very experienced basic surgeons located. They did a test. It's clear cornea, but they have found positive gene test. And then this is another case that also 20 years old female, and then gene test positive, but clinically very clear cornea. So now, does absolutely clear cornea with GCD2 exist? Do we need genetic test? Well, I cannot escape from saying yes. So only God can find out with a slit lamp. I'm a human ophthalmologist, but I've seen a lot of GCD2 patients for a long time, but sometimes I cannot find anything. And then my colleagues in Korea also could not find anything with this positive gene test. So do we need genetic test? Well, if you can diagnose this without genetic test, then you might not need that. But recently, just we do the genetic test routinely. And then this kind of mutation, TGFBI mutations, just show you once more. This is Avellino corneal dystrophy, GCD2. It's shaped like this. And this is LCD1, like this, and GCD1, and TL1K corneal dystrophy like this. But this one, sometimes very similar. And sometimes this one and this one is very similar. So if you want to find out, if you want to screen out for this kind of very 5 common things, just do the universal test. It will solve the problem. And then there are so many various mutations here. And so if you want to find out everything, then you will need this Avellino test. And this is a case came to me, and then I just checked that with the TGFBI gene, and then this L509P mutation. So because all of this TGFBI gene, TGFBI mutated gene problem is transmitted with autosomal dominant pattern. So I want to see his patient, his parents, and the parents, both of them normal. So I asked them to do the genetic test of whether this case is real son of them. They agreed and they were normal, but this one mutated. And then, we can check out whether this is a real son or not with other gene sequencing, and really they are the genetic father and mother, but this one, de novo mutation occurred. And then his son has a mutation. So if you want to know this kind of things, then Avellino test will be useful. And this one is type 3 things with this kind of very severe lattice lines, then we will also need Avellino test. And so I reported this kind of mutative things, especially exacerbated after LASIK, and everything. So now we can see that LASIK is contraindicated in GCD2 in this textbook in English, and also in other textbooks. So it's a kind of common sense from the textbook saying that LASIK is contraindicated in GCD2. Thank you for listening. And please ask me any kind of question if you have.
Thank you, Prof. Kim. I think you covered everything from the disease, how to look at it, the optometrist role on examination, using the slit lamp, and how long you can take in some cases. I mean, I was surprised that you took 20 minutes to see that small thing, which is really commendable, right? If you took 20 minutes, I think with that experience, we would probably take about a day to look at it. And Thank you. Thank you so much for sharing those cases and, bringing the importance of the genetic test, which is now available with the advancement of technology, so that we can kind of diagnose our patients better and, give them a good route of treatment, I would say, rather than just leaving them untreated.
Well, if you have just one joke to them, then just let me say like this. This case, one of the doctor who tested this one had been my previous fellow, and then he now knows everything about this case, and he's questioning like to me, Professor. Then doing this kind of tests needs money, and then when he does this kind of test routinely, that means his cost for the practice would be increased because of this test fee. And then so he asked me, Professor, from this case, do you think I should do the test routinely? Genetic test routinely? So I just answered them. It's up to you. You are doing your practice, and how can I control you? How can I push you to spend more money about this case? But now you are experiencing everything. And he answered me, yes, I have experienced this case. So this is a kind of joke, but it happened really.
Yeah, that's right. So it's really important that we kind of use this as much as possible if we can, so that we can diagnose. There is one question, and to the attendees, if you have any question, please feel free to put up on the chat. We will continue the second part of the sessions once we take up some question for Prof. Kim. I'm just going to read out to you, Prof. The question says that usually if the patient didn't do any LASIK, which activates the protein, meaning the person won't be able to have symptoms or progression at all. So it's basically asking that if the patient has GCD2, and if they do not undergo any refractive surgery such as LASIK, will they have any symptoms, or will the condition progress, or it will remain stable?
Okay, so just let's go back to the previous one then. Yeah. As long as the patient has that gene, then it starts like this, and with age, it progresses like this. Mm-hmm. Okay, so but if you touch the cornea with the laser or even knife, then it comes out like this within several years. So it will take about 50 years from this one to this one. But if you touch the cornea, then it will come out like this one within several years.
Right.
So anyway, it progresses with age.
Right. So it does progress, but then it becomes faster if you kind of do some procedures and touch the cornea, basically. Is that That's the basic understanding, right?
Yeah, but it aggravates very seriously.
Very
So that's
serious.
the problem. Okay.
That's the problem, right? Okay, thank you very much, Prof, for that clarification and showing up the case as well, because that the visual makes it more understanding to see the progression over the years. So thank you so much for putting that up. Okay.
Thank you.
Yeah. So thank you, Prof, for joining us, and we'll take any questions also at the end of the second session we have for today. And if you're around, we'll be happy to kind of get your inputs, but we'll definitely reach out to you if there are any questions from the attendees and get your feedback on that. So thank you so much for joining us today, Prof.
Thank you.
Yeah. So now we move on to the second part of the session, and we have with us Dr. Ryu, who is going to talk to us more about the role of the Avellino gene test before the laser refractive surgery in Korea. Dr. Ryu is a board-certified ophthalmologist and is working as an adjunct professor of ophthalmology at the Seven Hospital. He has graduated with master's and doctoral degrees. He is also very interested in artificial intelligence. He's done a lot of work in artificial intelligence as a system to predict vision correction, and is also called as the father of AI at the BNVITTI Center, where he is associated with. A lot of experience in laser vision correction, lens implants, and refractive procedures. He is specialized also in SMILE, which is also one of the refractive procedures for helping patients to see clearly. He's a key opinion leader for various companies, Zeiss, Meditech, Oculus Asia, as well as Alcon. And he also gives his input to Avellino about the genetic tests. So welcome, Dr. Ryu. Thank you so much, for spending this evening with us. And let's hear from you on what you have to say today.
Thank you. Thank you for a kind introduction. And I'm IKHee Ryu from Seoul, Korea, and I'm the Physician CEO of BMVIT Eye Center, which is one of the largest refractive center in Korea. And also I'm head of the artificial intelligence company called VisualWorks. And my financial disclosures are Avellino Labs, VisualWorks, Zeiss, Meditech, Alcon, and also Oculus Asia. I'd like to talk over about the role of gene tests before doing any refractive surgery to prevent the blindness related to the laser treatment. So I will go with the slides. As Professor Kim already talked about, we do find, not suddenly, but not many often, TGF-B1 corneal dystrophy time to time. It was first found in 1997. The genetic mutation was noted on the location of TGF-B1, and which is located in human chromosome number 5. As we already went through, there are five famous corneal dystrophy. I don't like to go over this very thoroughly, but as you can see, GCD1, granular dystrophy 1, usually comes with the hyaline formation just below the epithelium. We are talking about Avellino, which is used to be called GCD2, is a mixture of GCD1 and lattice dystrophy, which compounds the hyaline amyloid deposit for both in cornea. So GCD2 becomes very unique in appearance because it has some components of the granular, but also has some component from the lattice degeneration, which is quite different from its appearance. Rice-Buckless and Thiel-Behnke is very rare disease that we can see has sharing the same chromosome mutation, but it has some different clinical findings. Is that the patient will have some pain and redness and some visual discomfort due to those mutations because it involves with the Bowman's layer and has some elevation in epithelium and thickening so that the pain would be. Those the granular and lattice and the Avellino doesn't accompany with the pain, but these two will be having some ocular pain with the genetic mutation. As Professor Kim already reviewed the difference between the heterozygote and homozygote. Heterozygote means you have only a single mutation with the pair of chromosome. You can see 25 years old and 28 years old has only few spots when you have a heterozygote mutation, but where you have both a pair of chromosome mutated, even 20 years old and 24 years old at almost 100% blockage of opacity for the anterior cornea surface, which blocks the light passing through and touching to the retina and the optic disc, which will be interfering the visual acuity. So the question arose for the last talk that yes, it progresses after time to time, but if you have a heterozygote granular dystrophy, it will progress, but it will not interfere with the visual acuity a lot. But if you have homozygote, then you will be interfered with your visual acuity, even with the very young stage of age. We used to treat the granular dystrophy, including the Avellino, with the PTK, phototherapeutic keratectomy, which means we thought that get rid of those white dots with the laser will be the method of treatment for the granular dystrophy patients, but we already saw that it worsens after PTK after several years. In year 2002, the Professor Kim reported that the LASIK worsens the granular dystrophy type 2. That was the first report in the world that were associated with the Avellino gene. You can see the patient had no surgery on her right eye, but where she had the LASIK surgery on left eye only. She was undiagnosed with the Avellinos back then, but later on she was diagnosed with the Avellino, and you can see without surgery it got worsened very few, but with the surgery on the left eye, she was having very severe worsening of Avellino after LASIK surgery. We thought that it's very highly related to the Korean and Japanese, and also Chinese. But year 2006, there were a report concerning the worsening of Avellino after LASIK surgery in Caucasian. So we believe now it's not a matter of race. Of course, there will be some difference in terms of incidence, but it can be involved in all races all around the world. Not only for the LASIK surgery, for the refractive surgeon, I have to do PRK and also SMILE surgery nowadays. As you all know, SMILE has been very popular in China and Korea. And for myself, I'm doing more than 50% in my refractive practice with the SMILE surgery, where the LASIK and PRK has been decreased tremendously. For the PRK, it seems to be getting worsened a little bit less compared to the LASIK surgery, but it does have some exacerbation after PRK procedure. And you can see some difference between the pre and post-op for the PRK patient. Professor Kim published the article comparing the worsening between the PRK and LASIK, where you can see the LASIK has more worsening compared to the PRK. And this case is a very interesting case because the microkeratom, which makes a device which makes a flap prior to the LASIK surgery, was incomplete. So patient has only partial formation of LASIK. So the surgeon went through the surgery with the PRK over the flap. So you can see there's a little bit of more clear portion where the flap wasn't made. So this is only pure PRK portion. And this is the worsening portion was flap made partially with the microkeratom, which shows the definite difference between the worsening of Avellino from the LASIK versus PRK. What about SMILE? Professor Kim already talked about it can be, and it's very similar. Because the SMILE has been around us for only 10 years, we do not have a lot of information and also a lot of cases concerning the Avellino dystrophy, but the reports are coming out, and we believe that with the femtosecond laser, which is a lot different from the excimer laser, will be the stress to the cornea, and the Avellino and corneal dystrophy would be worsened by the laser stress. Okay, so for make a conclusion, the exacerbation, the worsening of the corneal dystrophy can be caused by UV or refractive procedure. So excessive production of PGF, TGF, B1 protein will be aggregated by the laser, and then we can see some protein deposit after surgery a lot. So it gets worse after laser vision correction surgery, regardless of modalities. So we have to find a way to prevent it. Let me introduce our BMVIT briefly. Our clinic is first generation vision correction center in Korea, which was established in 1994. We are performing more than 20,000 cases of vision correction every year, which means we are seeing a lot of corneal dystrophy patients every year. Without genetic test, we will be getting into big trouble, because often we do find very clear cornea, but the DNA test turns out to be positive. So where there were no DNA test available for us, then we were getting into trouble time to time. Year 2010, Professor Kim found out that the possibility of Avellino in Korean population is 8.25 out of 10,000 persons. So we decided to screen out corneal dystrophy by DNA sampling, and it is now a mandatory screening checkup for all the patients who want to receive laser refractive surgery in our clinic since 2009. We used to have only Avellino test available in Korea, but since a few years ago, we were able to use the Avellino universal test, which can detect 5 different corneal dystrophy with one swab. So we are now using it for our basic screen test for our refractive patients. And as you can see, we do have numerous patients who were detected positive from the gene test. For the Avellino test only, we were able to find 3.65 out of 10,000 patients. But after universal test, we found 7.9 out of 10,000. We don't exactly know why there is some difference between the Avellino versus universal, but we think that because of the volume of the surgery has been increased in our clinic, so we have more patients coming in, then we have more chance of having patients being positive, where the number is reaching closely to the 8 point something, which was published by Professor Kim. So since 2009, we saved 104 patients from getting blind if there were no genetic tests for the patients who are willing to do the laser refractive surgery. So the necessary for the genetic test is already been discussed. Also, I will skip that. To take home message, granular dystrophy gets worse by laser, especially laser treatment. Not enough with familiar history taking or slit lamp examination. So even a single dot would not be seen on cornea by slit lamp examination, so that to protect our patients from the severe clinical outcome caused by corneal dystrophy, the DNA testing would be needed strongly. It's not an option. It's a strong pre-op screening test that needs to be done for all patients who are seeking for the vision correction surgery. So thank you for listening. That's my talk. Thank you.
Thank you, Dr. Ryu, for that reinforcement of what Prof. Kim said, and also, bringing out the numbers of what you have been doing in the practice and in the clinic, and saved so much of lives in terms of vision, save so much of vision for the patients, which really would have been affected if not for the genetic test. So thank you so much for enlightening us with these information.
Thank you.
Great. So I'm just going to read that first question. There are a couple of questions which have popped up. The first question says that the test is allowed only in Korea, and can we do this? Can we do this on a patient schedule for corneal graft? Have you have an experience in terms of patients with corneal grafts?
You mean the for the donor graft?
Testing? Donor or donor probably graft, patients.
Yeah. Usually, currently the Avellino test and universe test is done by the swab in the mouth. So you are getting the DNA from your mouth epitheliums. So I don't believe that it's possible to detect the Avellino from the donor cornea, because there's only eyes available for the donors. But for the recipients, of course, you can do the DNA sampling before the surgery, that why did cause the blindness or even the severe damage to the cornea that need to be replaced by the cornea transplantation. And I don't know exactly what the situation in each country, but because I think that the Avellino lab company is expanding their business toward the Asia market. So more and more countries will be available with the Avellino test and also universal test. So it may differ from country to country. So please ask the Avellino company later on whether your availability of the Avellino test or universal test.
Yeah, thank you. Thank you so much, Dr. Ryu. And as you mentioned, the company is doing its efforts, and we have Mr. Prabal, who is joining us today from Singapore, who heads the Asia Pacific region and is responsible for bringing this test for us, probably in the near future. So, Mr. Prabal, if you would like to, address this and give us some thoughts on this, yeah.
Sure, Abhi. Thank you, Dr. Ryu, for the wonderful presentation, and appreciate your time. So as from Avellino's side, I would also like to thank every participant here, the viewers who are seeing it. This is a Sunday. There are different time zones, of course. Coming to the question which was raised now. So universal test and Avellino test, both are available in Korea, because we started in Korea for about 15 years now. And the universal test itself is available in Japan. It is also available in China. So these are the three countries in Asia which is available at present. So we have commercialized it. The next countries where we are going to have it from 2023 onwards, it will be in phases. It will start with Singapore, then Malaysia, then India, and gradually the whole of Southeast Asia. We will then go to Australia, New Zealand, and Taiwan, Hong Kong. So in the next 2 years, probably there will be almost all the prominent markets in the Asia Pacific region. We will be having our presence. So you can look forward to that. And Avellino will be doing its own digital marketing campaigns through different platforms like this, and also through YouTube channels and LinkedIn and other places where you will get the information of when the test is available. I hope I answered the question.
Great. Yeah, thank you so much. I think after this Power Pack presentation, a lot of us are waiting for that test. And I hope this will be available soon in the markets where people are joining in today, so that we can take the advantage of this at the earliest.
I would also like to add one more thing, FP here. So the test that we are talking about, which is universal and Avellino separately, these are PCR-based tests, right? So these are like single gene. And now for diseases which are multi-genetic, like keratoconus or glaucoma, the test will be done through the NGS method, the next generation sequencing. And the name of the test kit is called Avellino, as you might have seen the logo during Prof. Kim's presentation. So in phases, again, we will start with universal kit, and then we will have Avellino, which will take care not only of corneal dystrophy, but also of keratoconus and glaucoma. And again, it's just a matter of time, probably in 2023, Q4, or later, we will have it present in the Asia Pacific region. But Avellino is already available in the United States, by the way, where it is used for keratoconus and corneal dystrophy.
Yeah.
Wonderful. Great. So we'll be waiting for it. And yeah, please do follow, the social media channel of Avellino. And, they keep on updating that so that it kinds of let us know if once it is available in our market. So you can do that as well. And we will be at Online Optom Learning Series, will be very closely working with them as well to kind of bring to your notice on when these tests would be available. Let's go to another question which just popped up. And this, Dr. Ryu talks about the refractive surgery in terms of cataract. So we did talk about refractive surgery, LASIK, and getting all of that patients help. Any thoughts on prior to cataract surgery, if these tests needs to be done, and would that become a bit more of a hindrance for cataract surgery patients?
Yeah, you already saw very numerous images of Avellino patients. You definitely find out that it's mainly involved in the central portion and paracentral area. Because of the periphery of cornea adjacent to the conjunctiva vessels, usually Avellino doesn't appear to the limbus area and very close to the periphery of cornea. When you have the cataract surgery, your incisions are mainly involved in limbus. So theoretically, it will not be interfering the progression of Avellino with the cataract surgery. But nowadays, we use femtosecond lasers to make incisions and also do some capsule laxus. But the capsule laxus matter, the laser passes through the cornea, not hitting the cornea itself. So we don't have exactly what is happening during the femtosecond laser shooting for the cataract surgery right now. We have to look thoroughly after a few years what happens to the Avellino patients after having the femtosecond assisted cataract surgery. So that will be our next plan, next experimental phase for the femtosecond assisted cataract surgery. But for the routine conventional cataract surgery, it didn't have any effect on the progression of Avellino.
Wonderful. Great. So it's something in the pipeline which needs to be kind of looked at. Because the technology in advancement is there for cataract surgery. As you said, we are now no incision cataract surgeries and things like that, where you use the lasers for doing the incision. Probably that's the thought process which comes to the mind, where we are using laser for the incisions, and that could probably be something which can be looked at in the near future, as you mentioned. Right. The other question, I think, probably is a bit more concerning in terms of the primary eye care kind of group of people we have today, is the age limit and what is the youngest patient you can do the test? Is there any criteria of doing these tests in your settings? Probably, yeah.
The advantage of the gene test is there's no limit for the age. If the patient is cooperative with the swab on their mouth, I think that the age doesn't matter. Even with the very young age, have a DNA test run over and being detected as negative or positive. If it turns out to positive, then there are numerous ways to protect and also prevent the progression of Avellino, so that knowing their genetic characteristic as early as possible will be a best way to prevent the progression of the disease. So that if a member in family turns out to be positive, we strongly recommend all the other members of family come into clinic to go over the genetic test to find out whether their types and whether it's positive or negative, and then we can make some family plan for the treatment of the corneal dystrophy.
Yeah, right. And the whole advantage, it is non-invasive, like as we did
Right.
recently, we are doing the COVID
Right.
test. So it's
Right.
exactly the same.
Yep,
Right?
very same as COVID test.
Yes, so it can be done in all age groups.
Right.
Great. Okay, so if there are any questions, we will wait for a couple of more if we have time. One quick question, Dr. Ryu, just from my side is, when do you normally do this test? Do you do it for all patients, or you are now looking at any red flag patients where you want to do the test? I mean, you did mention your practice is more of a refractive, but are there such patients which you say that, no, I have to do the test no matter what? Are there any red flag criterias? The reason I'm asking you is, since we don't have the access of the test, what do you think we should be looking at this point where, okay, these are the things where genetic tests would be really important?
For my practice, we go through genetic tests for all the patients.
All patients.
We don't make some selections and we don't find a red flag. But because you don't have any access to these kind of genetic tests, I think that you have more thorough chair time on the slit lamp to see the surface of cornea more thoroughly, because acknowledging that there will be some patients coming into your clinic with the corneal dystrophy without any significant white dots on cornea. So you have to look very thoroughly on the cornea surface. And then if you find a single dot, that's very suspicious, because you never had any Avellino before. There will be some confusion whether this is from the contact lens problem or even other opacities that naturally occurred, or is it really corneal dystrophy. Then you have to go through the genetic test to find out whether it's a genuine genetic problem or just a simple corneal opacity related to other causes.
Right. Okay. Wow. So that brings us to a very important point. So careful examination is what we can do, and use the slit lamp and look at it very carefully. Any other specific instrumentation? Like I saw a couple of pictures of the anterior segment OCT in your and Prof. Kim's presentation. Do you think that would be helpful in some suspect cases for us?
But because it's the showing the phenotype, so what is happening on cornea is not the definite diagnostic tool. So it will be helpful, but it's not definite diagnostic procedure. So you should have genetic test to finalize your diagnosis.
Right. Okay. And we'll just take one final question on your experience on the accuracy of tests. In your practice, how do you think it has fared in your experience?
After the Avellino test was launched, in Korea back in 2009. Because of the full impact on the refractive surgery, there were a lot of generic company who follow the Avellino labs to do the PCR tests related to the Avellino detection. But most of the company is gone away because of the low sensitivity and low specificity. So the strong point from the Avellino is that the accuracy of the test is nearly 100%. So even with the false positive, false negative from the other company, we run through, not for myself, but few surgeons who choose to run their tests for the separate other company, had the positive or negative, they will be seeking Avellino for reconfirmation of the result. So that's the very strong point for the Avellino lab right now. It's based on US and has office in China, Korea, and Japan, and expanding their business into the Asian Pacific area. So I don't think that you don't be being very worried about the reliability of the genetic test, and the swab is very simple, as is easy as COVID test. So you don't have to be very worried about the accuracy of the test. I think that you will be very confident after you once used it.
Yes. All right. So thank you so much, Dr. Ryu and Prof. Kim, for this wonderful presentation, and going through us with the disease as well as the importance of the detection and the use of genetic tests for patients to help in their vision correction and making sure that their vision is preserved. So thank you so much, Dr. Ryu.
Welcome, my pleasure.
Yeah. Mr. Prabal, any parting words before we kind of end for today, and I'll leave the screen time to you.
Yeah, sure. Thanks again, FB. So on behalf of Avellino, I would again like to thank OOLS for giving us this platform. And a big thanks to our esteemed speakers, Professor Kim and Dr. Ryu, for taking out their time and sharing their knowledge about and their experience about using the test for a very long period of time since the inception of the test itself, and probably the company itself. We have been very lucky to have you all as our esteemed customers who believe in the products that we have and use the products for the betterment of the patients. Just to know that X number of patients were prevented from having a vision loss or blindness itself is very heartwarming for me, at least. There's one point I would like to mention that, as Dr. Ryu was saying, that it's very easy to take the test itself because it's a swab. So the swab is taken from the cheek. It's a buccal swab. It is similar to COVID-19 test. But COVID-19 is from the nostrils or from the throat area, but it is much more simpler than that. And Avellino does the training for the nurses and the staffs of the clinic how to take the test. And we also have got genetic consultants who help the patients if they have any questions. So that is what will be in the new countries as well when we will be launching. So with this, apart from OOLS, our speakers, I would also like to thank our participants here for spending their time today, coming up with a couple of questions. I would ask you to follow Avellino in different platforms that you have. And through OOLS, we will be sending you more updates about new products, or even if there is a new clinical paper or a white paper which is there. If you have any questions, you can send it to Fakhruddin or to myself, and we'll be happy to get back to you on this. Lastly, and not the least, the team that we have here in Asia Pacific is mainly in Korea, and hence today we have my colleague, Dr. Yoon, and without his support, this wouldn't have been possible, to connect the dots and getting our speakers in and hosting this occasion itself. So Dr. Yoon, thank you to you and to your team for the support that you always provide to us.
Thank you, Prabha. Thank you all.
So thank you to the attendees. We do have session planned on next weekend. We will be sharing the details about it, and anything with regards to today's session, please feel free to contact us and we will get you connected with the lab and with the people at Avellino who are very kind enough to solve your doubts and queries. So until then, take care, be safe, and I will see you again next week. Bye-bye.
Thank you.
Thank you, FB.
Yeah, bye-bye.
Thank you.
감사합니다. 원장님 감사합니다. Goodbye, Prabha.
Bye-bye.